Hey everyone, welcome back. This is Dr. Dilip, your medicine faculty at Cerebellum, and today we're going to have a quick discussion of all the medicine questions that was asked in the recent UPSC CMS 2024 paper. We have around 40 questions to discuss. Precisely speaking, it's 38 questions, and they are quite simple, straightforward, easy, and they're direct lines from standard textbooks. And because they are kind of easy questions, it should not take much time for us to discuss. Let us move on to the first question straight away. Here is your first question. The height of the jugular venous pulse is determined by what? It's a kind of a question that should be asked to a first year medical school student. So the answer is going to be right atrial pressure because the jugular veins are directly attached to the right atrium. And jugular veins in fact act as a manometer for looking at the pressure changes that happen within the right atrium during various phases of the cardiac cycle and during pathologies and even during various phases of respiration like inspiration as well as expiration. Even though it has a slight bit of correlation with the right ventricular end diastolic pressure in the absence of tricuspid valve problems, the direct correlation is going to be with the right atrial pressure. And that's the reason why whenever there is a process that cuts off the transmission of pressure from right atrium to the jugular veins is going to result in absent pulsations of the jugular veins. So example of such condition is going to be SVC obstruction. Let us move on to the next question. SI node is situated at the junction of, again, a first year medical school kind of a question. It's located at the junction of the superior vena cava and right atrium. Third question, high output cardiac failure is caused by which of the following diseases? They have given very severe anemia and thyrotoxicosis. All of the three are correct because we know high output cardiac failure is something that's going to occur in conditions that cause hyperdynamic circulation. What are those conditions? Severe anemia, thyrotoxicosis, especially thyroid storm, beriberi, especially the wet form of beriberi we talk about, that's due to thiamine B1 deficiency. Then it can occur in AV fistula, Paget's disease. There are so many conditions that can result in high output cardiac failure. So here, of course, the answer is going to be 1, 2, and 3. Coming to the fourth question, reverse splitting of the second heart zone is most commonly seen in which of the following conditions? The right answer is going to be left bundle branch block. In left bundle branch block, the LV contraction is going to be slow and the completion of LV contraction is going to take a lot of time. So that's why the A2 is going to close very late and it can go away from P2, and that P2A2 sequence of splitting is what we called as reverse splitting of the second heart zone, or otherwise called as paradoxal splitting of the second heart zone. And not only in left bundle branch block, even in conditions that delays the ventricular contraction significantly, like severe LVOT obstruction, like severe aortic stenosis or severe HOCM, also can result in reverse or paradoxal splitting of the second heart zone. And why not ASD? Because ASD tend to produce wide fixed split. Why not severe MR? Again, severe MR is something that's going to produce wide split along with severe VSD. And pulmonary hypertension is something that produces narrow splitting, but definitely not reverse splitting or paradoxical splitting. Let us move on to the next question. Which of the following are major criteria under the Jones criteria for acute rheumatic fever? So here the only controversial thing is polyarthralgia, because in high risk population, even polyarthralgia can be considered as a major criteria, but here they have given only 3 options, right? In all of your answers, they have given only 3 options. So that's why I can safely ignore that polyarthralgia. Definitely, Cerebellum chorea is a part of major criteria. Erythema marginatum is also part of major criteria, and subcutaneous nodules are also part of a major criteria. That's why major criteria can be remembered in the mnemonic called as cases. So C stands for carditis, A stands for arthritis, typically a migratory polyarthritis, not arthralgia. S stands for Cerebellum chorea, E stands for erythema marginatum, and another S stands for subcutaneous nodules. So the mnemonic is going to be cases. And the right answer for this question is going to be option A, 1, 2, and 3. Going to question number 6, a 70-year-old man with dyspnea on exertion has been found to have single second heart sound with a loud diamond-shaped rough quality systolic murmur, best heard in the right second intercostal space, which means they're talking about right upper sternal border, and it is radiating to the right carotid artery. Which of the following is the likely diagnosis? It's a very easy question. Everything is in favor of aortic stenosis, including the age. Everything is in favor of valvular aortic stenosis. Patent ductus arteriosus is something that's going to produce a kind of a continuous murmur. In children, ventricular septal defect will produce a pansystolic murmur. Okay, and this will be seen in the left lower sternal border. Pulmonary stenosis can produce an ejection systolic murmur, but it will be in the left upper sternal border, not in the right upper sternal border. And of course, the age is not fitting into any other diagnosis except aortic stenosis in this question. The right answer is option C. Coming to question 7, which of the following is the appropriate scoring system used to assess the risk of stroke in patients with non-valvular chronic atrial fibrillation on oral anticoagulation? We have discussed that thousands of times. Answer is going to be CHA2DS score. Curve 65 score is used for pneumonia, especially community-acquired pneumonia. As-blood score is used to assess the risk of bleeding in patients who are receiving anticoagulation and atrial fibrillation. And AMT is abbreviated mental test score. This is not related to atrial fibrillation, at least in this question. Going to question number 8. Consider the following statements with regard to pulmonary embolism. This is actually a straight line from Harrison. Unexplained breathlessness is the most common symptom. Of course, when congestive heart failure and pneumonia fail to improve despite standard medical treatment, occult pulmonary embolism should be considered. Definitely, this is a true statement. And patients with high clinical likelihood of venous thromboembolism should first undergo D-dimer testing alone without obligatory imaging test. This is a wrong statement because in patients who are having high clinical likelihood by Wells criteria, these patients should undergo imaging. Like for example, a compression ultrasound if you are suspecting a DVT, or probably a CT pulmonary angiogram if you are suspecting a pulmonary embolism. So they should be undergoing imaging and not D-dimer testing. D-dimer is only for patients who are having a low likelihood of venous thromboembolism by Wells criteria. So only 1 and 2 is correct. 3 is obviously wrong. Coming to question number 9. Consider the following criteria. Pleural fluid protein to serum protein ratio more than 0.5. Pleural fluid LDH to serum LDH ratio more than 0.6. This is 0.6. And pleural fluid LDH more than 2/3 of the upper limit of normal of the serum LDH. All these three are part of something called as Leitz criteria. So Leitz criteria is a criteria to define a exudative pleural effusion, right? So even if 1 out of 3 criteria is positive, we can call it as a exudate. The sensitivity of criteria is almost like 99 to 100%, but the specificity is only 80 to 85%, which means it's not very specific. That's why we have other criteria in modern practice, but nevertheless, so all 3 are correct. So because all 3 are indicative of a exudative effusion as per the Leitz criteria. Coming to question number 10, which of the following statements are correct with regards to clubbing? It usually affects fingers symmetrically. That's a true statement. It does not involve toes is wrong because clubbing does involve the toes as well. It may be associated with malignant lung conditions, correct. For example, lung cancer, mesothelioma, anything can produce clubbing. It may recede following treatment of certain conditions. For example, if you do lung transplantation in patients with cystic fibrosis, clubbing may recede. So it's basically kind of reversible once you reverse the underlying cause. So 1, 3 and 4 is correct. So right answer for this question is going to be option B. Coming to the 11th question, which of the following statements is true regarding Lofgren syndrome? That's what the examiner is asking. First option, it's an acute illness and is more commonly seen in females. Absolutely correct. In fact, it's a self-limiting condition. Most of the time, steroids is not even required and you can just treat these patients with supportive management. It will resolve automatically. It has a very, very good prognosis. Option 2, it's a clinically distinct phenotype of sarcoidosis characterized by peripheral arthropathy and uveitis. Peripheral arthropathy is definitely a feature of Lofgren syndrome, but whether uveitis is a feature of Lofgren syndrome or not, answer is definitely not. But it's a controversial thing because examiner has taken this question from Davidson straight away. Because in Davidson, under Lofgren syndrome, they have given uveitis, but in fact, uveitis is a feature of another syndrome called as Hereford syndrome or Hereford-Waldenstrom disease. So uveitis is actually not a feature of Lofgren syndrome. But because it's given in Davidson, the examiner has taken the question from Davidson. According to examiner, I can say that option 2 is also correct. And option 3 states clinical features include fever, erythema nodosum, and bilateral hilar lymphadenopathy. Absolutely right statement about Lofgren syndrome. So I will actually go for option D. All 1, 2, 3 are correct. Going to the 12th question. Which of the following investigation may be used for the diagnosis of pulmonary tuberculosis? Of course, nucleic acid amplification, that is CB0 or PCR, is a very, very important test in modern practice that improves the sensitivity of diagnosis of pulmonary tuberculosis. And culture in Middlebrook medium is also correct because Middlebrook medium and its modified versions are the ones that are used in various liquid culture media. And fluorescent LED technique with aromatase staining is something that is going to improve the visibility of the tuberculosis bacteria. So that's why that is also correct. I'm going to do nothing with peripheral blood smear. Peripheral blood smear does not yield anything with regards to pulmonary tuberculosis. That's why I'm going to go for options 1, 2 and 3 which are correct. So the right answer is going to be option A for this question. 4 is obviously wrong. 13th question, the distance walked in 6 minutes is an indirect measure of which of the following variables in the BORD index which is used to assess the prognosis in chronic obstructive pulmonary disease. BORD is actually an acronym for BMI. Second, obstruction. Obstruction is predicted by something called as FEV1. And D for dyspnea. Dyspnea is predicted with the help of modified MRC scale or MMRC scale. And E for exercise capacity, that is assessed with the help of something called a 6-minute walking test. So it's basically a test of exercise capacity. The right answer for this question is simple, straightforward, option D. Coming to 14th question, a 65-year-old female, a stone cutter by occupation, has multiple well circumscribed nodular opacities in the upper and middle zones of chest X-ray along with mediastinal lymph node showing eggshell calcification. Which of the following is the most likely etiology? Here there are multiple clues for the diagnosis of silicosis. Right answer for this question is option B, silicosis. But what are the clues here? Number 1, stone cutter by occupation. Of course, miners, stone cutters and sandblasters, these are people who are at risk of developing silicosis. And to be honest, silicosis is the most common occupational lung disease in the world. And they are having circumscribed nodular opacities in the upper and the middle zones, which are also very, very characteristic of silicosis, even though it can occur in other conditions like cold workers pneumoconiosis. But this is very characteristic of silicosis. Another thing that is so characteristic of silicosis is that eggshell calcification, which is something that we have discussed plenty of times in our lectures as well. The right answer for this question is, of course, silicosis. Byssinosis is something that occurs in the setting of a person who is working in cotton industry. And berylliosis is something that's going to occur in a setting of a person who is working in either nuclear or aerospace industry. And siderosis is a completely different condition we are not going to discuss right now. Move to the next question, 15th question. A 40-year-old female with nephritic range, not nephrotic. Nephrotic means more than 3.5 grams proteinuria. Nephritic means somewhere around 1 to 2 gram per day proteinuria is found to have low serum complement levels. Typically, they're talking about low serum C3. Which of the following is the likely etiology? SLE. SLE 100% tend to produce hypocomplementemia, low C3, C4, and post-infectious glomerulonephritis. Like for example, after infective endocarditis or after streptococcal infection, you can get glomerulonephritis, and definitely that is going to be associated with hypocomplementemia because of complement consumption. Infective endocarditis is actually a kind of post-infectious glomerulonephritis only. That's also going to be associated with low complements. And mesangiocapillary glomerulonephritis is also called as MPGN, that is mesangial-proliferative glomerulonephritis. There is also one condition that's going to be definitely associated with low C3. So the right answer for this question is going to be all 1, 2, 3, 4. So I'll go for option D as the right answer. 16th question. Consider the following clinical features. And they're asking which of the features given above are generally present in patients with Parkinson's disease or Parkinsonism. So option 1 says hypomimia. Hypomimia is reduced expressions or expressionless face, which is very characteristic of Parkinson's disease, even though in advanced stage. Dysphonia. They will have that soft spoken speech and monotonous speech, that is characteristic Parkinson type of dysarthria, that's what they call. But nevertheless, this is a feature of dysphonia and Parkinson's disease. And fist and gait, we all know, is so characteristic of Parkinson's disease, and cogwheeling is also very, very characteristic of Parkinson's disease. We know the typical trap manifestations, right, in Parkinsonism. The T stands for tremors, R stands for rigidity, A stands for akinesia, and P stands for postural instability. These are also called as cardinal manifestations of Parkinson's disease. And the right answer for this question is option A, 1, 2, 3, and 4. Moving to 17th question, circuits between basal ganglia and motor cortex constitute the extrapyramidal system, which controls the muscle tone, body posture, and initiation of movement. Lesions of the extrapyramidal system present clinically with. Of course, the right answer is going to be tremor and rigidity, which is a characteristic feature of an extrapyramidal problem like idiopathic Parkinson's disease. Option B and C, in some situations, it can occur in extrapyramidal problem, but they're not very typical. Muscle wasting is a feature of a lower motor neuron disease, right? We don't see that in patients with corticospinal tract lesions, that is pyramidal tract lesions, or even in extrapyramidal tract lesions. In both these conditions, preservation of muscle bulk is characteristic. So right answer for this question is option A. 18th question, consider the following statements regarding transient global amnesia, and you have to say which of the statements are correct. The first statement states that TGA mainly affects middle-aged persons who present with abrupt discrete loss of antegrade memory lasting for few hours, very, very characteristic of transient global amnesia. And second statement states during the episode, patients are unable to record new memories, resulting in repetitive questioning. This is very, very true. In fact, this repetitive questioning is so characteristic of TGA. And consciousness is impaired during the episode, and patient is unable to perform even simple motor functions. Very, very wrong statement. In fact, consciousness is preserved, fully preserved throughout the episode, and patient will be able to even perform complex motor tasks. So that's again a characteristic feature of TGA, and because of that, I can say the third statement is wrong. And fourth statement states that after 4 to 6 hours, memory function behavior will return to normal. True statement. But the Patient has complete and persistent amnesia for the entire duration of the episode is also very, very characteristic of TGA. So except the third statement, the other three are correct. So I will go for option B. That is 1, 2 and 4 is correct. So going to 19th question, consider the following statements regarding cluster headache. First statement states the headaches are periodic beginning at the same time for weeks at a stretch. And in fact, this is so characteristic of cluster headache, and this is the reason for the term cluster headache in that typical headache that we are discussing. So the headache tends to come in clusters and it tends to occur for a period of weeks, and after a period of weeks it tends to go for remission, and it can last for even month to years, and after that again the headache tends to come in clusters, typically going to affect the middle-aged men, especially in the 30s and 40s. And patients experience severe unilateral periorbital pain which lasts for 30 to 90 minutes is also right statement. In fact, the typical duration of cluster headache is going to be somewhere around 30 to 90 minutes or 30 to 180 minutes depending on the textbook you read. And you're going to have the typical periorbital pain, and it's going to affect only one side. In fact, these trigeminal autonomic cephalgias are so characteristic that's going to affect only one side of the face and head, and that is the reason why they are termed as something called as side locked headaches. The most common type of trigeminal autonomic cephalgia is going to be the cluster headache. And option 3 states the headache is accompanied with autonomic features such as ipsilateral tearing, nasal congestion, and conjunctival injection. So this is a very, very correct statement. That's the reason why these headaches get the name called as trigeminal autonomic cephalgias. And option 4 states that subcutaneous injection of sumatriptan and inhalation of 100% oxygen at maybe 12 to 15 liters per minute can result in halting of approximately 95% of the acute attacks of cluster headache, which is also a true statement. The important thing to know is that oral sumatriptan is not effective. Only subcutaneous sumatriptan, or probably some studies say intranasal sumatriptan, inhalation of sumatriptan also is going to be quite effective. But the usual treatment that we use for cluster headache is 100% oxygen inhalation. So all 4 is basically correct. Going to 20th question. A 22-year-old lady presents with complaints of chronic daily headache. She has a past history of migraine, but increasingly unrelieved with analgesics. She has a history of using sumatriptan almost daily since the last 3 weeks. What is the most likely diagnosis? So somebody is using analgesics, especially for more than 10 to 15 days per month, is at risk of developing a type of headache called as medication overuse headache. And the only treatment of this type of headache is going to be withdrawal from analgesics. But if you withdraw from analgesics, the background migraine can exacerbate. So you need to explain all these things to the patient very, very carefully. And going to the 21st question, considering the following with regards to trigger factor for seizure, which of the factors given above are correct? Of course, flickering lights is a trigger factor. Recreational drug use like cocaine use or opioid use is definitely a risk factor. Poor compliance to treatment with anti-epileptic drugs, of course, is going to be a risk factor, and sleep deprivation is also a very, very important risk factor, especially for generalized seizures like juvenile myoclonic epilepsy. Flickering lights is a very, very important risk factor, especially again for generalized seizures. The right answer for this question is 1, 2, 3, 4. All are correct. Coming to 22nd question, a 75-year-old man presented with temporal headache, jaw pain exacerbated by chewing and talking. So definitely, looking at the age and the symptoms, this is a case of giant cell arteritis, otherwise called as temporal arteritis. Which of the following investigation will most likely help in the diagnosis? We all know that gold standard for diagnosing giant cell arteritis is going to be temporal artery biopsy, or we can say superficial temporal artery biopsy, where we are going to demonstrate the granulomas. The first line treatment of choice is going to be corticosteroids. And GCA is also associated with another very important disorder called as polymyalgia rheumatica, or PMR. 23rd question, Roy staging system and Binet staging system are two widely used staging systems for staging which of the following hematological malignancies? Of course, it's going to be CLL, chronic lymphocytic leukemia. If it's only going to involve the lymph nodes, it's also called as small lymphocytic lymphoma. 24th question, patients suffering from which of the following conditions commonly present for several years in the dermatology OPD with eczematous or dermatitis skin lesion before being finally diagnosed as T-cell lymphoma? The T-cell lymphoma that's going to masquerade as a skin problem is going to be mycosis fungoides. The disseminated form of mycosis fungoides, if the tumor cells enter the peripheral blood, that's also called as Sézary syndrome. We're going to see the characteristic Sézary cells in the peripheral blood that going to have that characteristic cerebriform or folded nuclei. Other options are obviously wrong. It's an easy one. 25th question, which of the following is a cause of secondary hyperaldosteronism? Aldosterone secreting adenoma or bilateral adrenal hyperplasia producing high aldosterone levels are basically kind of primary hyperaldosteronism causes. And 11-deoxycortisone secreting adrenal tumor is also going to produce primary hyperaldosteronism model. Inadequate renal perfusion due to renal artery stenosis is a characteristic cause of secondary hyperaldosteronism. Because of reduced perfusion to the kidneys, there will be increased renin release, and that renin will activate angiotensin 2, and angiotensin 2 is going to act on the zona glomerulosa of the adrenal cortex via the AT2 receptors, angiotensin 2 receptors, and that's going to increase the aldosterone levels, and that is basically a secondary hyperaldosteronism. The right answer for this question is option D. Moving to 26th question, which of the following disease is characterized by destructive lymph node infiltration of the thyroid gland leading to fibrosis and enlargement of the thyroid gland and an increased risk of thyroid lymphoma? Typically, they're talking about a disease called as Hashimoto's thyroiditis, where you're going to have elevated anti-TPO antibodies, but the main reason for destruction of thyroid gland is cell-mediated. It's going to be due to T cells, especially CD8 T lymphocytes. They are the ones that are going to cause destruction of the thyroid follicles. And lymph node infiltration is so characteristic, and it can even result in germinal center formation. And because of chronic lymphocytic infiltration, you're going to result in significant fibrosis. Initially, there will be enlargement, but later on, the gland may become atrophied. And Hashimoto's thyroiditis, for that reason, it's also called as chronic lymphocytic thyroiditis. And Hashimoto's thyroiditis patients are at risk of developing two cancers. One is thyroid lymphoma, even though the risk is small, but still the risk is there. And there is a small increased risk of papillary thyroid cancer as well. Decurrence thyroiditis patients are not at increased risk of any cancer. In fact, it's a subacute form of thyroiditis, and it's a painful form of thyroiditis. And these patients will have granulomas on histology, not lymphocytic infiltration. And what about multinodular goiter? Multinodular goiter patients will have an enlarged gland with various sized nodules within them, and more than lymphocytic infiltration, they'll be having like enlarged follicles, thyroid follicles. That's what I'm going to see in these patients, and these patients are at slightly increased risk of follicular thyroid cancer and not papillary thyroid cancer. Riddle thyroiditis is a very different form of thyroiditis. It's a fibrosing thyroiditis, and it's a form of invasive fibrosis, and these patients are not at risk of cancer, even though the most important DD for riddle thyroiditis is anaplastic thyroid cancer. So right answer for this question is option D, easy one. 27th question, which of the following regarding cortisol is correct? Levels are highest in the morning on waking. Very, very true statement. In fact, cortisol levels are going to peak by approximately 7 a.m. to 8 a.m. in the morning, and the levels are going to be at its rock bottom in the night. By 11 p.m. to 12 a.m., the levels are going to be at its bottommost. And cortisol levels fall dramatically during illness is wrong statement, because cortisol is a stress hormone and it's going to increase during illness and stress. More than 95% of circulating cortisol is protein bound. An absolutely true statement. In fact, most of the cortisol is bound to a protein called as cortisol binding globulin. Statement 4 states that it's the major glucocorticoid in humans and can activate the melanocorticoid receptors also. We have discussed that so many times in our lectures. Because of this ability of cortisol to bind to the melanocorticoid receptors, organs that are going to respond to melanocorticoids are going to have a specialized enzyme to inactivate cortisol. So we have discussed about that, and if you do not have that enzyme, it's going to result in something called as SAME, that is syndrome of apparent melanocorticoid excess. The right answer for this question is option A. Option A correct, because 1, 3 and 4 is correct. 2 is definitely wrong. It's an easy question. Coming to question number 28, a patient presents with history of bones, stones and abdominal groans due to generalized aches and pains and renal calculus colic. What is the most important discriminatory blood investigation? Of course, the clinical picture is so typical of primary hyperparathyroidism. So I'm going to go for parathyroid hormone assay. Calcium and PTH level assessment is going to be the most important in this patient. And of course, if it's a primary hyperparathyroidism, I'm going to see high calcium with high PTH. 29th question. With regards to the treatment of thyrotoxicose of Graves' disease, consider the following statements. Propyltyrosol is suitable in breastfeeding patients. That's actually a true statement. In fact, you can give any antithyroid drug at low doses if the patient is breastfeeding. So PTU is not an exception. In fact, PTU is very much indicated in two situations. One, of course, in first trimester of pregnancy. Second one is going to be in thyroid storm, where it's going to be the drug of choice. And large goiter is an indication for thyroidectomy. Thyroidectomy is actually declining as a part of therapy in patients with Graves' disease. We often go for radioactive iodine ablation, or maybe we can maintain with antithyroid drugs also. But yes, if the patient is having large goiter that actually has a cosmetic implication, then you can offer thyroidectomy for these patients. The most important absolute indication for thyroidectomy in patients with Graves' disease is suspected thyroid cancer, but even though it's rare in a setting of hyperthyroidism. And radioactive iodine is recommended in pregnancy is absolutely a wrong statement. Radioactive iodine is never recommended in pregnancy as well as in lactation. In fact, it's contraindicated. We all know that. Agranulocytosis is a complication associated with carbimazole as well as methimazole. So it's actually a right statement. So 1, 2 and 4 is correct. So I'll go for option C. Going to 30th question, with regards to management of hypothyroidism, consider the following statements. Treatment is going to be levothyroxine replacement. For any hypothyroid patient, subclinical or overt hypothyroidism, the treatment of choice is going to be levothyroxine replacement. So it can be taken as a single daily dose because the half-life of levothyroxine is approximately 7 days. You can take it as a single daily dose, not a problem. Average dose is approximately 1.6 microgram per kilogram per day, which is also correct. So in a 60 to 70 kilogram person, the average replacement dose will be 100 micrograms per day. Full dose per weight should be started in those with coronary artery disease. Very, very wrong statement. In patients with ischemic heart disease and coronary artery disease, you have to start at a lower dose, maybe at around 12.5 to 25 micrograms per day, and slowly you have to uptitrate depending on the TSH values. If you start with a higher dose, it can result in tachycardia and it can even result in arrhythmias like atrial fibrillation, and even sudden death risk is there. So definitely this is a wrong statement. So right answer for this question is option A. 1, 2 and 3 are correct. Moving to the 31st question, consider the following statements regarding acute respiratory distress syndrome, and they are asking which of the following is correct. Statement 1 states that exudative phase lasts from day 7 to day 21 after exposure to a precipitating risk factor. This is actually a wrong statement because from 7th to 21st day, it's actually proliferative phase and not exudative phase. So day 1 to 7 is going to be your exudative phase, and after that, after 21 days is the proliferative phase where there will be proliferation of type 2 pneumocytes, and after 21st day it's going to be fibrotic phase of ARDS. Statement 2 states that proliferative phase is characterized by proliferation of type 2 pneumocytes. Correct. Third one, low tidal volume ventilation, that is 4 to 6 ml per kilogram body weight, has significantly lower mortality in management as compared to high tidal volume ventilation. Absolutely correct. In fact, this is one of the proven things in the management of ARDS. It's one of the things that has a very good mortality benefit. And option 4, PaO to FaO ratio, that is PF ratio measured with a PEEP of at least 5 centimeter of water above, and if it's less than 100, it's classified as severe ARDS. It's not AIDS, it's ARDS. That is also correct. In fact, if the PF ratio is less than 300, we call it as mild ARDS. If it's less than 200, we call it as moderate ARDS. If it's less than 100, we call it as severe ARDS. Right answer for this question is option B, because 2, 3, 4 is correct. 1 is obviously wrong. 32nd question, which of the following are used in the management of hyperkalemia? 10% calcium gluconate used intravenous. That's correct. In fact, this is one of the first things to do in a patient with hyperkalemia because this is going to cause stabilization of the membrane potential, which can give you some time so that you can correct the hyperkalemia. So because during that time, you have to prevent the risk of developing ventricular arrhythmias. So that's what is done by calcium gluconate IV. And regular insulin intravenous glucose is also very correct because regular insulin is something that's going to activate sodium potassium ATPase so that your potassium from ECF is going to go into ICF, so that there will be a transient lowering of the serum potassium, which can be life-saving at times. Intravenous sodium bicarbonate is also correct, especially in patients with acidosis. Soda bicarbonate also tends to create an alkaline environment in the ECF so that it can push the potassium from ECF to ICF. So it's also going to transiently lower potassium in patients with acidosis and renal failure. And nebulized ipratropium bromide is wrong because ipratropium bromide is a SAMA, that is short-acting muscarinic antagonist. The SABAs, that is drugs like salbutamol or levosalbutamol, they are the ones that are going to activate sodium potassium ATPase so that potassium can be moved from ECF to ICF, which can be protective in patients with hyperkalemia, not ipratropium bromide. So that's a wrong statement. So right answer for this question will be 1, 2 and 4. So I'll go for option B. Third is obviously wrong. And 33rd question, nebulized salbutamol is used in the management of which of the following electrolyte abnormalities? Obviously, just a while ago we discussed, the answer is hyperkalemia. Because beta-2 agonists tend to activate sodium potassium ATPase, we know that. 34th question, which of the following statements are correct regarding anti-glomerular base membrane disease or anti-GBM disease? It's a rare autoimmune disease which presents as rapidly progressive glomerulonephritis. Most of the anti-GBM disease will present with RPGN, and it's also called as type 1 RPGN. Antibodies are formed against the alpha-3 chain of type 4 collagen that is present in the glomerular base membrane. Absolutely correct. And alpha-3 chain is expressed in basement membrane of glomerulus, and the retina is wrong. It's actually expressed in the lungs. Pulmonary capillaries, that's where it's expressed. It's not expressed in the retina. The disease may be associated with retinal hemorrhage And when it is associated with retinal hemorrhage, it is also called as Goodpatcher syndrome. This is also wrong. So it should have been pulmonary hemorrhage. Then it would have been correct. So 3 and 4 are wrong. So I'll go for option A. 1 and 2 only is correct. Coming to 35th question, consider the following findings in urine examination of suspected hematuria. They're asking which of the following triplets is correctly matched. So option A states B, F, and G. So B, hematuria, and F means red cell cause, and G means glomerular bleeding. This is the one that's correct. Other three are obviously wrong because the second one states A, D, I. A is myoglobinuria, and D means white blood cell cause. No, you don't see white blood cell cause in myoglobinuria. That itself is wrong because white blood cell cause are commonly seen in patients with acute intestinal nephritis and probably in patients with pyelonephritis. B, E, and H, hematuria, they have given no red cells. Of course, that's wrong. I mean, B and E itself is not matching, so I can ignore this. C, F, and H. So hemoglobinuria, and they are given red cell cause. Of course, in hemoglobinuria, you don't even see red cells. It's just hemoglobin pigment. So that is also going to be a wrong match. So B, F, and G is a correct match. So I'll go for option A. Moving to the 36th question. The next two questions are actually straight from Davidson textbook of medicine. You can see the nephrology chapter. There will be some tables, and if you see them, you will understand why these questions have been asked. Which of the following are poor prognostic indicators in glomerular disease? The table in Davidson textbook says that male sex is a risk factor and not female sex. So this is actually a wrong statement. Hypertension is a risk factor for poor prognosis. Persistent and severe proteinuria is also a risk factor for poor prognosis, and elevated creatinine levels, that is renal failure at the time of presentation, is also a poor prognostic indicator in patients with glomerular disease. So 2, 3, and 4 are correct. 1 is obviously wrong. 37th question, which of the following are indications for a renal biopsy? Again, this is from a table that's given in Davidson textbook of medicine. First statement states that chronic kidney disease of uncertain etiology, in fact AK or CKD of uncertain etiology, we can go for renal biopsy to sort out the issue. And nephrotic syndrome is a very important indication because we need to go for immunofluorescence that gives you vital information about what is the type of nephrotic syndrome that you are dealing with. The classification of nephrotic syndrome is itself based on your immunofluorescence findings only. And uncontrolled severe hypertension is actually a contraindication for renal biopsy because of risk of bleeding. Renal transplant dysfunction, especially if you are suspecting allograft rejection, acute rejection, transplant biopsy is the gold standard, and use the band classification for it. We have discussed that. So right answer for this question is going to be 1, 2, and 4. Option B. Coming to the final question, that is the 38th question. Which of the following is the correct range of GFR for stage 2 CKD? Stage 1 CKD means GFR of more than 90. Stage 2 CKD means GFR of 60 to 89. Stage 3 CKD means GFR of 30 to 59. Stage 4 means 15 to 29. Stage 5 means less than 15. So the right answer for this question is going to be option A, 60 to 89. That indicates a stage 2 CKD. 45 to 59 is going to be stage 3A. 30 to 44 will be stage 3B. And 15 to 29 will be stage 4 CKD. So that's it. We have completed the UPSC CMS 2024 paper as well. Hope you have enjoyed the session. Thank you very much. See you in the next session soon.